exercise in a week, huh? Is it? The percentage was a third. Huh? Yeah. Okay. So you even understand, even us who are discussing health, how difficult it is. But it's not difficult. Don't wait until the last minute. Yeah. So local solutions. So as I present very few slides, very few, less than 10. The point is local solutions. I'm not coming here with complicated solutions, complicated strategy. What we are talking about is just local, because that is what we are seeing bring results. Next slide. So we've all been discussing about what these things are, conditions within the space of non-communicable diseases, and the big four. Here in Kenya, also we are talking about cardiovascular diseases, cancers, diabetic, chronic respiratory tract conditions. And these things are related, but we are not saying these are the only ones. Because here in Western Kenya, we also have conditions like sickle cell disease because of our intermarriage practices. So, and we are having now a discussion to the village. I know the religious people here, you've gone to church. Usually, before marriage, there's counseling. You've heard of that. Counseling, there's HIV test. Hello, I'm talking to someone, Yes. So the question is, should we bring the discussion of genetic counseling in that counseling session or before? So that is one of our nightmare we are having also in this region, because of the very many crises. You felt our weather, it's chilly, Cindy, and there are times it comes hot, okay? Yeah, so these patients also suffer great deal, and that's one of the conditions that we also throw in as very important, and we have to follow up. Darren mentioned about epilepsy, okay? Epilepsy is also an issue in this part of the world, this part of the country, because of stigma. Stigma, it's an issue. Why am I saying that? If my child has epilepsy, in the village, I hide them. Why? Because people say it's a curse. And they will not associate me in their discussions. If they are brothers, they'll say, that home, leave it first. Call the others. You get? So social discrimination, it's a lot. It's a lot in this part of the country. And it's one thing I just have to mention, we also deal with. We have woken up, and I had Darren mentioning that he's really focusing on bringing the leadership here, especially during the conference. And for me, it's a plus. For me, as the head of Cancer and Non-Communicable Diseases unit, I'll feel that you're helping me to trigger the leadership to start discussing. Because if they don't understand, remember, they're the ones who are budgeting. And at all cost, as I said, we are looking at local solutions, okay? You're not using your chest to force them understand. You have to understand their language, bring them on the table, and negotiate. Help them understand the burden, as simple as you will be explaining to a baby. Once they understand, they will start thinking that direction. And bring it home. Bring it home. Tell them it is affecting their kindreds, their relatives. And it will reduce even the amount of money they spend to take them to hospital, care for them. At all cost, I was asking a friend yesterday, do you usually budget for malaria management at your home or flu management? Do you? The answer is no. But patients who have non-communicable diseases, they have to budget. And they can know the cost they will incur in a year because it is there. They have to plan for their drugs every month. They have to plan for their food. They have to plan for whatever, transport, because those are indirect costs, which I'll mention later. So, and this, having said this, it gives you the picture of how we would like to ensure the leadership understand that 50% of hospital admissions in Kenya, they are due to non-communicable diseases, meaning that translates to you have to budget for this, and you are able to budget. The other 50%, you can do your probability. Because for communicable diseases, how many times did you have a flu this year? It's not something that is predictable. Okay, yeah, and there's need for prevention. There's need for early detection. There's need for planning for treatment and support. And when I say support is the community support, and to family. The family also needs to understand, and that is why we have to bring. We usually have support groups. We bring them together and sit down with them, and bring caregivers. Start discussing on what this means. Okay, what it means, how you should take care of this patient, how you should reduce the cost, and tell them, make them understand, rather than trying to increase stigma and tell them. Like an example, in the past, we used to have families cooking for a diabetic patient their meal, and then they cook for theirs. You understand that? You understand that? Huh? Yeah. You have a family cooking for themselves, then they cook for this child who has diabetes. We are telling them, stop that. Just cook one meal. And portions. Local solutions. Globally and regional context, so that I don't repeat what Darren mentioned, our strategy borrowed a lot from the WHO Global Action 2013-2020 and WHO African Regional NCD strategy. Also, the focus basically, as was presented, was to reduce premature NCD-related mortality. Next slide. Premature NCD mortality by 25%, and our target is by 2025. It's already here, 2030. I know we've not done so much about it, okay? But as I said, I see light at the end of the tunnel, because I'm seeing people discussing about NCDs. You know, in the past, we were discussing about malaria, especially in Kenya. Malaria, tuberculosis, HIV, what is the other one? The flus, okay? And we were not asking ourselves, what about high blood pressure? What about diabetes? Because many of the patients who come at A and E, they come, we confirm them dead. They are due to a heart attack. Why? We don't know the cause. And we've come to realize most of the causes are myocardial infarctions, okay, heart attacks, okay? And they could be because of late detection or no detection. And someone doesn't know has this condition. And that's why the strategy was developed to try and curb these deaths, 2021-2025 strategy. We'll revise it depending on the data that we've collected. This year, we are going to start a step survey. A step survey, basically a survey on NCD risk factors, prevalence, and any challenges within the community. That's what we are depending on right now. Reason being, the health management information system, a system that will help us to get day-to-day clinical data on the number of patients we have in the community who visit the facility, and are they in control or not, is not as good as we expect. But we can't sit and just wait. Hence, we do a step survey to understand, so that we can keep on discussing with policymakers. Because when you go to policymakers or leadership, they'll ask you this question: how many patients have diabetes? What will you say? Because you don't have a good HMIS system. So you'll need to work with the prevalence that you've done from the community. And this STEP survey will advise on the next NCD strategic plan, okay, which is meant to end this year. And our goal basically is to reduce the premature mortality by 25 at all cost. So NCDs account for 33% of all deaths in Kenya. However, after Raymond finishes his presentation, I'll shock you with the comparison. So 33% of the deaths in Kenya are due to non-communicable diseases. And that, as I mentioned in the previous slide, no, next slide, sorry. In this slide, in the previous slide I'd mentioned that our target is to reduce by 25%. However, the data that we have is from a STEP survey. We have to do a STEP survey for us to understand the dynamics, okay? But this 33% is not as accurate as we expect, because there are patients who don't know that they have these diseases. And that is why a strategy that has been embraced countrywide, and it is global, using community health promoters to help in screening so that we can reduce late detection and complications. So having said that, we are having rising numbers of diabetes and hypertension, and the new, we call it the new baby in the strategy is mental health. Mental health is a big issue. I know with your humanitarian service, you understand what I mean. Mental health is crazy in the community. The fact that the burden is high, people are depressed, where will they get the money? That is a very big factor. Will this patient really survive? You see, these are questions that they ask themselves. And unfortunately, like in this county, let me say country first. In my class, my medical school class, we've lost 3 colleagues from mental health issues. That's suicidal. And those are healthcare workers. When it comes to this country, last year alone, we lost 4 healthcare workers, suicidal. So I've not gone to the community, right? I'm still within the health space. So even us, it's a big issue. Let's not look at it as a very small issue. You know, it just sounds mental health. But you need to understand, get to understand how close is it to you. And the key drivers to these non-communicable diseases, as we will be discussing later, are things to do with urbanization, lifestyle changes, and we were discussing during tea break. You know, in Kisii, this is a space that is growing in terms of urbanization, and people are liking it more and more. A safe space, someone saying that you were told Kisii is safer than Nairobi. Have you heard of that statement? Yeah, and it's making this county to be more urbanized. As I'll give the next talk, you'll understand how the burden is increasing because of that. In addition to that, our lifestyle, how we eat, how we move from one place to another. I don't know whether you've walked from Kisii University to town. Do you understand the distance? Not yet, huh? Okay. Or from where we are to the VC's office. Not yet. You use the van, huh? Now you're starting to have the poor lifestyle that we are also embracing. Okay, try to walk. Okay, and we have tobacco, alcohol use, and poor diet, which it will be discussed later, and how bad it is. So this is our prevalence in the big 4. That's at 12% for cardiovascular diseases, 4% in the country, and 7% for cancers, then around 3% for chronic respiratory diseases. However, as I said, our HMIS is not that good, our health management information system, but using our step survey, we get this data. Maybe next year, when we publish the next step survey, I'm very sure the numbers will be worse than this, because we have increased modalities of screening, and this will give us more data, more cases in our prevalence. This was done when the NCD space was not actually funded, okay? But now there are more partners coming in. Next slide. Next slide. Yeah, there are more partners coming in to fund the NCD space, and the numbers are getting worse. Currently, cardiovascular disease, using the STEP survey 2019, 12%, diabetes 4%, cancer 7%, and chronic respiratory diseases at 3%. However, as I've said, they're going to get worse. Next slide. To finalize on this, as I welcome Raymond on the Kenyan strategy. Next slide. I'd like to mention that our priority areas, just as our vision states, is to ensure that we have a Kenya free from preventable NCDs and avoidable NCD-related deaths, because we can prevent obesity. True or false? Yeah? We can prevent obesity. Okay? If we are intentional. You know, the issue is intentional. We have to make people understand. And lifestyle change is very important, as will be discussed. So that is our, no, go back. That's our vision. And we have 5 priority areas in our strategy. We prevent and ensure we have health promotion. These are health talks to the village to make everybody understand. It's not a healthcare worker business. It's not just training healthcare workers. It has to be to the village. And all these are intentional aspects that are being done from the ministry up. We are having budgets being put together with implementing partners or related stakeholders coming together, and I'm happy. You see, like Manchester is another big stakeholder to give you ideas, to bring us together and have this discussion. And I'm very sure, as I usually tell my students, start with your wife and your children. Do they understand what you know? Okay, ask yourself that. Or you think village is them, not you. You know you're part of the village. And if you start with your wife and children, get them understand, make it as simple as possible. Not the way you are in another level. You're understanding more difficult things. But for them, they don't understand any. But can you make them understand even how to change their lifestyle? Then early detection is one thing, and screening is one thing that the ministry is advocating for, especially going out to schools, to villages, to carry out things like cervical cancer screening. Currently, as a ministry, any child who's between 10 to 12 years is getting HPV vaccine, and every woman of reproductive age is being given free cervical cancer screening. Okay? Those are strategies that are coming in, and you understand, strategies coming because, first of all, you look at what do you have. You can't say every woman should get HPV screening for free, and you don't have those resources. Is it so? Yeah, you have to come up with a strategy that is sustainable and that is realistic. Okay? And that is why the age group is picked. You vaccinate that age group and you screen these women. And from there, there's an age group that will have to undergo pap smear, okay, and other complicated testing. So start from somewhere as you go. And that is why we're saying there's light at the end of the tunnel. Thirdly is access to care and treatment. And this is made possible by ensuring that healthcare workers are being taught, okay? Regular teaching to understand, give them guidelines, give them updates on what is happening currently, what is supposed to be done, so that when they meet these patients to the primary care level, we are not just focusing on the tertiary level, as Darren mentioned. We are focusing up to the primary care level. They know how to screen. What are the normal levels of diabetes, hypertension? What should they expect to see in a patient they are screening for? Cervical cancer, breast cancer, sickle cell, hemophilia. Okay? And we are focusing on surveillance, monitoring, and evaluation. And I'm glad that many and most counties are embracing monitoring and evaluation. And we are procuring HMISs that we are focusing right now on integrating the HMIS system from the community, where we have what we call ECHIS, ECHIS. It is software that is used by community health practitioners or promoters to collect screening data or disease data from the community, and they refer those patients who have the condition to facilities. But now we want to integrate that system to the hospital-based HMIS systems, which are varied. There are many. There are many in the country. Mombasa has, Kisii has, Kisumu has. There are different types, but we would like that each is to integrate. After that, we integrate that to the countrywide database. I don't know whether you've had KHIS, Kenya Health Information System. You can visit that on Google Chrome using a visitor's ID. You just see Kenyan data in that platform. So that is where we are heading to. And those are improvements that are going to be done in phases. And there has to be a buy-in, because there's a lot that is going on in the political space. Because if Kisii has an HMIS, Kisumu has an HMIS, they don't want to have the same HMISs because of 1 or 2, 3 reasons. I know Kenyans who are here understand the politics and finances. And this is, I don't think it is only in Kenya. It's many countries. You know, usually people ask, what is in it for me? You've heard of that statement? Yeah, leaders usually ask that question. And lastly, is the governance multi-sector coordination. In this case, is what I mentioned, that we have to ensure leaders understand, so that when we come to ask them to include us in the budget making process, they're able to understand why. It's not that we want to eat the money. No, we want an objective budget, a budget that will be sustainable and realistic. And lastly, it's to include a multi-sectoral approach where we have many stakeholders in TWG, technical working groups, to discuss and give opinions on what should happen in agriculture and related to health, or education related to health. Like currently, we are having an issue with schools, and especially with type 1 diabetes patients, okay? Like in this county, we have less than 2% control. You know, control, we use a test that we call HbA1c. So that HbA1c, only 2% of the patients we have 398 patients who have type 1 diabetes in this county. Only 2% have attained control. Reason being is there are questions about when my drug is over, I can't come to hospital to pick it because of 1 or 2 things from the schools. The school does not have a fridge, so the question is, do you really need to put in a fridge? Those are the discussions we're having, and that is why, as stakeholder, like the education sector, is very important for us in the NCD space, including the sickle cell sticklers. Okay, the teachers have to understand what this is, because they are having the children for longer durations than even parents. Okay, so they need to understand even the complications or the danger signs of these conditions. So we have to bring them together, and even the security space accounts name them, and that is why the strategy included that coordination in the strategy. Yes. So my second last slide on this talk is just the interventions that from the strategy, the interventions that have been put in place in the various counties. Next slide. Yes. Those 4 important interventions on NCD clinics, these are, we call them medical outpatient clinics in the various hospitals, level 4s and 5s. But as Raymond will come to discuss on the levels of care, you'll understand what these levels are. These other smaller levels, we focus on the screening. Then we have integration into primary care, ensuring that every nurse, every clinical officer, every staff working in the health sector understands how to manage this or how to screen these conditions. Secondly, thirdly is have public campaigns like the tobacco control, physical activity. You know, in Kenya, we have tournaments, soccer tournaments, and these have been encouraged by the increasing burden of non-communicable diseases. Next weekend, I'll be attending a tournament in Kenyatta University that is has been organized by doctors. Then towards the end of next month, I'll be attending a tournament organized by lawyers. Okay? So this is the communication we are giving them. It is important to have these tournaments. And you know, before tournaments, there has to be exercises. So it means that these people have to schedule their physical exercises. Okay? Yeah. As big as I am, I play soccer. Yeah, I play soccer. We started a football club here in this county so that we can embrace or encourage people to improve physical activities in our big hospital. Maybe as you're here, you might visit it and just understand where it is. Okay? It's called Kisii Teaching and Referral Hospital. And lastly, health financing strategies. There's an animal that is called SHA. I know it's not 100% embraced by the Kenyans. I know the Kenyans who are here understand what I mean. It's a social health authority which provides social health insurance. There are teething problems, okay? But I usually tell people who are not working in civil service, it is better by far than NHIF. However, those ones who work in civil service or in public sector or in even the private sector, whatever they pay is more than 3 times what they used to pay with the former health insurance fund. So they will say they are getting a raw deal. I know those ones who are deducted who are here, but it's a social scheme trying to bring together all the resources from all over the country, put together, and we help just bring some equitable financing. I know it's from my perspective, it's better for them. However, for me, for you, as the one who's being deducted as an employed person, I know you'll feel you are getting a raw deal. However, it's a discussion that it's ongoing. We hope it will be a win-win situation for all. Lastly, these are the policy frameworks or legal acts that we are using to come up with this strategy from the Kenya Health Policy 2014-2030, which ensures that there's something that is called UHC. You've heard of UHC, Universal Health Coverage. Okay, this Kenya Health Policy is as clearly stated universal health coverage to ensure that everybody gets health service equitably. Okay, no discrimination, even the disabled. It states that they should get service without pay, and they should also be paid for, even this SHA. You say it covers the whole picture. The essence is to ensure to embrace universal health coverage. Tobacco control, there are key areas that are mentioned there to ensure that those who are underage are not sold for these products. Advertisement of this product is regulated. there's a group of enforcers who are given permission or rights to go and check the selling points to regulate this. It also goes down to discuss about how many sticks should be sold. I know somewhere in the past, people used to just buy even one stick. But now, right now, if you sell one stick, it's illegal. So this is an act that is regulating that. Even the Alcohol Drinks Control Act, aka Mututo Law. I know the Kenyans understand this Mututo. I love this guy when he brought this idea of controlling the alcohol consumption and who to be sold to, when to sell, from what time to what time. Okay, these are regulations that are helping in reducing the burden of non-communicable diseases. And we have the Cancer Prevention and Control Act, which has defined clearly who should be screened, how it should be screened, how to teach those ones who are supposed to screen, okay? Regulate who should treat, like we have the National Cancer Institute, which controls which institutions should give chemotherapy, radiotherapy, okay? And these regulations are important to ensure we get quality of health. And lastly, we have the Mental Health Act, as I said, the new baby in town, okay? Yeah, this is to ensure that we also understand that mental health is important. Thank you very much. As I welcome Raymond to take up to the next presentation. Thank you.
The Kenyan healthcare system. You've heard from Dr. David Okinye about NCD's national strategy. Then from there you'll know about the healthcare system in Kenya, so that now we come to the county level. Okay. Who is fixing the slides? So basically, the Kenyan healthcare system is a dual system with both public and private sectors. Both of them are important, and the patients choose either. Okay, so most of the time they choose what is nearest to them, or they choose what they think is a better service. But it's a dual system, which probably you'll find is the same in where you come from in your countries. So it's a dual system with both public and private sectors. And it is structured into 6 levels, ranging from community units to national referral hospitals, with a mix of government-funded, private, and even faith-based facilities. And we are all under one umbrella, the Ministry of Health, which is responsible for the overall governance and policy, while the county governments manage the healthcare at the local level. So again, there are those 2 arms of government. It's a dual system, public and private, and dual governance. The national government and county governments. Before we went into county system, we were all under one national government. I think it's on the site, you can see it, something here. Okay. So the next slide, maybe you can look at the sites meanwhile as they look at the. So the Ministry of Health is responsible for the overall governance and policy, while the county government manages the healthcare at the local level, as I've said. And you can see the Ministry of Health is actually under what is called the Cabinet Secretary. Then we have the Principal Secretary. Then you have a Director General, Deputy Director General in that order. At the county level, you have somebody called the County Executive Committee Member for Health. That's the same as Minister in the national level. Then you have a County Director of Health. Then under the County Director of Health is when you have people like Dr. Okenye, who is the focal person for Dr. David Okenye, who is the focal person for NCDs and all others. Then now you come to the sub-county medical officers of health in that way. Next slide. So if we start with the public healthcare system, there are 6 levels as we saw. Level 1, we have the community units, where the community health workers provide basic healthcare services at the grassroots. It's really just at the villages, community units. That's the level 1, all right? Then level 2, you have the dispensaries and clinics, which offer primary care services, including outpatient consultations and basic diagnostic tests. That's level 2. They're really basic now structures. Level 1 is more of community in the villages. Level 3, then you come to health centers, where they provide a wide range of services than dispensaries. Remember, level 2 were the dispensaries, including, so in level 3 now you have maternity care, which is not found in level 2, right? And of course some laboratory services again, which are not found in level 2. So the difference with level 2 is that level 2 there's no maternity and very basic diagnostic tests. If we go to level 4, we have the sub-county hospitals, which offer more specialized care, including inpatient and surgical procedures. So in level 4 now you start admitting the patients, doing patient services, have theaters, okay, cesarean sections and other emergencies, okay. Basic surgical procedures. Then you come to level 5, which is the county referral hospitals, the main referral centers for each county. And each county, according to the government, should have a county referral hospital, providing comprehensive specialized care and diagnostic services. Then level 6 is the highest level. That's where you have the national referral hospitals, the highest level of public health care, which in Kenya is represented by 2 main hospitals, Kenyatta National Hospital and Moi Teaching and Referral Hospital. There's a debate whether Coast General Hospital is there and another one in Othaya. So those are the level 6 hospitals. And certain faith-based hospitals are also at level 6 status, Kijabe and Tenwek. Right. Again, about governance, the Ministry of Health, we talked about that. The Ministry of Health providing the overall leadership, while the county governments are responsible for healthcare service delivery within their respective jurisdictions. But the main leadership is provided by the ministry. And as Dr. Okenye said, there is a social health insurance fund that helps alleviate the suffering of the poor by giving the social health authority that provides insurance. Next slide. So, what about the private healthcare? Private healthcare facilities, we have private healthcare providers, which include for-profit hospitals, clinics, and even others who are not for profit. Then you have the faith-based organizations. They play a significant role in providing this subsidized healthcare in Kenya. There are a lot of mission hospitals, and they really help quite a bit. Then you have the non-governmental organizations, again providing healthcare services, often focusing on specific areas of populations. And some of the non-governmental organizations are even allowed to run hospitals, okay? Then private insurances play a big role in that, and they link up with these hospitals. Next slide. So what are the key features and challenges of these systems that we have? Number one, it's a dual system, as we saw. There will be duplication, there will be of roles, there might be some kind of rivalry in quotes, varying levels of access and quality of care problems, but we have regulatory bodies that take care of that. Funding gaps is another challenge, where we have the public healthcare system faces challenges, okay, due to inadequate funding leading to shortages of resources. That is really quite common in the developing countries, not just Kenya. So you have shortages of resources, shortage of personnel, and this is, in fact, that's why you have areas like Embu and Homa Bay, where you had NCDs being taken care of by the MSF because of weaknesses in the public healthcare system. Okay. Infrastructure limitations. Some public facilities lack adequate infrastructure and equipment, particularly in the rural areas. Human resource gaps, we have talked about that, shortage of doctors, nurses, healthcare professionals. But again, it's because of priorities, it's because of funding, not that the personnel are not there. Right, next. The universal health coverage is another feature that has come in Kenya. Government being committed to achieving universal health coverage. I hope that will be done, Dr. Kisii. Are we almost achieving it, Dr. Kisii? Universal health coverage? We are far. Yeah, it's difficult. That's why the insurance was brought in, but again, people are not able to meet the obligations in paying the very little money for the insurance. I don't know whether the insurance was meant for that universal health coverage, but maybe you'll talk about it again when you come back here. Community health strategy. There's a Kenya community health strategy emphasizing primary health care, community engagement. So it supports this structure that we talked about. And then, of course, the social health authority, the insurance body. So if we look at these levels again, in terms of personnel, we said level 1, community health unit. The personnel are mainly just community health workers. Services, mainly prevention and promotive. Okay, really just detecting and referring. Early detection is very, very important. The community health practitioners. If it was done properly, it will prevent a lot of illnesses. It will enforce adherence, it will enforce defaulter tracing. Level 2 facilities, we talked about them, the clinics, various clinics, health clinic, dental, dispensaries. Next slide, please move. Move to level 2. Yeah, so that's level 2 facilities, the health clinic, the dental clinic, dispensaries. Next slide. The mobile clinics, the eye clinics, all those are level 2 facilities. And even home-based care services, right? Next slide. Even a funeral standalone. You've heard of UMASH and all that. This is a level 2 facility, all right? Where autopsy undergoes and all that. If we go to level 3, we talked about they are classified into level 3A, a comprehensive healthcare center that has got almost everything. Health facility that provides comprehensive, curative, preventive, promotive, rehabilitative, and maternity services. Level 2, there's no maternity services. So when we reach level 3, now you start getting all those. Next. 3B is slightly less, general medical and dental. Next. 3C, just the basic health center, okay? That has been gazetted as a health center, offers many ambulatory health services and generally offers preventive and curative at appropriate local needs. Next. Then we go up higher, level 4 facilities. That's the hospitals now. We have 4A, a primary care hospital, a principal primary referral hospital. That's the one we call a sub-county referral hospital. It offers services that complement the primary care services to allow for a delivery of a more comprehensive care. There are more personnel, there are more senior personnel there. Your medical officers there and even some consultants. Next. Level 4B is a specialist standalone medical center. You hear of specialist hospital and all that. Next. Then we come to level 5. That's where our hospital here in the county stands. A health facility that is secondary, is a secondary referral hospital. The primary referral hospital was the sub-county hospital, the level 4. And this provides services offered in level 4 and more comprehensive set of services together with internship services for the medical staff. They can do internship, okay? They can do research. They can serve as a training center for paramedical staff and all that. And level 6, next. Yeah, and then you have 6A, which is a national teaching and referral hospital like Kenyatta National in Nairobi, or like Moi Referral. Okay, then level 6B, specialized hospitals. So these are facilities that offer specialized services exclusively, or a group of specialized services, all right? Maybe like a specialist kidney center and all that. That is level 6B, all right? I think that's the last slide. Is there another slide? So those are the levels we have. If you have any questions, you can ask. Sorry for the initial hitch about the technical services. Okay. Yes. Thank you.
Thank you, Raymond. As we transition back to David, give David a moment to come up. Sorry about the technical challenges. The IT team are trying to fix it, but there are screens on the side for you to be able to see. It says, well, we'll rehearse it before we've got 100 of you in the room. So breathe, it'll get sorted, and they fixed it. Thank you very much. So we have a sandwich of David, Raymond, back to David, who's going to be more local. Non-verbal communication with the IT.
Yeah, just return the first one, huh? And you'll be ready with the second presentation. Just go back to the first one, where we had left, the last slide, on legal policy framework. Yeah, as he's coming back, as he's putting up the slide, there was that slide that Raymond had mentioned on UHC in relation to SHA. Yeah, UHC is not equal to SHA, or SHA is not equal to UHC. However, SHA, it's a building block of UHC. That's how I look at it. SHA supports the implementation of UHC. So UHC basically is to alleviate financial burden and to provide quality of care. I know quality of care has 6 principles or core values, from safety, okay? So healthcare has to be safe. Because this patient has come to you, believes in you. You know, in our community, but it's all over. The patient know that you are God. Whatever you say, it's God. That's all. They'll follow what you've said. Okay? So, as they trust you, please don't harm them. Usually, we are usually told, do no harm. Okay? So, secondly, it's timeliness. So, this service, as they come to the facility, let them not stay from morning till evening. Something they could get within 30 minutes. Okay? Because you are increasing their burden. You're making them not go back into their hustle. Remember that? Remember, this is a mama mboga, or this is someone who's hustling, buying potatoes or tomatoes from some big market to go and take it to the village to hustle to get 100 shillings or 20 shillings for supper, and you want to keep that person a whole day waiting for a service that you can give within an hour. Okay, so think about that. Efficiency, the resources that you are being taxed. I know all of you are being taxed in one way or another. Okay, it might not be a lot, but that small resource need to be used appropriately and avoid wastage. Effectiveness is the service you give needs to come out with an outcome. It has to give results. Fifth, it's patient-centered. You know, we know a lot. These patients believe in us. But as you treat this patient is not the same way you'll treat this patient. That is why it is patient-centered. Also look at the cultural diversification. Okay? So the way you'll manage this patient has to be patient-centered. Okay? And lastly is equitability. It has to be equitable. So we have those ones who are abled differently. That's how we refer them nowadays. And you who's abled that way. So the way we manage these two is different. It has to be, you consider that, and you consider this person either is a hustler, this person is rich, how you will have to give this medical service. It's different. So UHC ensures that the goal is to ensure that we alleviate financial burden and provide quality of care. So SHA is just to try and help we attain UHC, but it's not equal to UHC. I think from that simple context we can champion UHC wherever we go, because this is a global fight to ensure that we provide quality of service and we provide safe health, quality health. And Kisii County perspective, next slide. As we've looked at the national perspective in strategies, Raymond has taken us through the various levels you've seen. We have the national government and we have the county governments, okay? And health is devolved. However, not 100%. We know that. The national government has the policy arm and also champions a lot of training. And that is why we use that strategy. We customize it to the county level so that we are all going the right direction. So the 5 principles have to also be embraced in the county level. Okay, so basically in Kisii County, the burden is on the high, and the main facility that usually treats majority of our patients, more than 70% of our patients, is Kisii Teaching and Referral Hospital, which is located at the town center, somewhere within town, at the heart of town. And when you look at the profile of patients we have, most of the patients within the non-communicable disease unit are hypertensive patients, diabetic patients, oncology patients. Mental health patients are on the rise. Though, as I said, the data is not that good, but we hope as we move along in this county, we are piloting our health management information system in 2 facilities. That is this Kisii Teaching and Referral Hospital, and another facility which is next, second biggest, which is called Gucha Sub-County Referral Hospital. Once we see that this HMIS is able to answer our questions, then it will be rolled out to all facilities. However, all health facilities, 160 of them public hospitals, they have a health management information system at the patient support centers where we manage our HIV patients. However, because of, I know you've heard what Trump did. He really beat us very hard. Global funds were reduced. You heard of that? Yes. So it gave us a shocker, and I usually say, for me, it's a blessing in disguise, in the sense that the leadership are now focusing. Yes, the small taxes that we have, can we now budget on these conditions? We've been 100% depending on donor funding, and it is possible. I know Kenyans, you understand this, that we are eating more than what we are using to give service. Do you know that? Yes. The answer is yes. Huh? Yeah. So if we can reduce our eating and put that money where it's supposed to be, we will also save. Studies are showing when you invest on prevention of care, you save on the curative arm. Because the curative arm, remember, there are complications. You guys, there's one or two of you who was ever come into contact with a relative who's managing a complication of an uncommunicable disease. It was cheap, is it? Very expensive, okay? Yeah, I know some of you were included in WhatsApp groups and you contributed 2 million, 3 million, okay? But if you had noted this condition before it became a complication, you'll have used 50,000, 30,000, okay? Yeah, so that is the perception we want all of us to have. And that is what we are telling the government, that, hey, let's reduce the burden by budgeting on the prevention of care. That is why we are ensuring, as Raymond mentioned, we improve on our HMIS, we understand our demographics, profile properly, so that we know where to budget. And the emerging issues, and as I mentioned, mental health, renal disease is another nightmare. I know in this country, many facilities are putting up dialysis units. You've heard of that. And they're making a lot of money. Is it? They're making a lot of money. A friend of mine put up 3 years ago. Right now, he's driving a very big car and living in a very big house. Just because we didn't take care of the primary health care. Now we were put in WhatsApp groups. I know many Kenyans here have contributed to their relatives, and those relatives have gone to his facility and they've been dialyzed. He's made a lot of money. He's driving big cars, okay? So what we need to change our mindset. We need to change how to work on this. And those are the emerging issues, and they're increasing the burden greatly. Next slide. Just to show you, in Kisii Teaching and Referral Hospital, those are the patients we have in numbers. I know that facility, the HMIS, is better than whatever we have in the lower facilities. It's a level 5, okay? It's a level 5, as Raymond has presented. I know there are politics that in the university here, some of them could be referring it as level 6. It's just to remind the lecturers who are here, that facility is not called a level 6. We've had that statement. You've been using it outside there. Even your relatives know that that facility is a level 6. It's not a level 6. As Raymond has mentioned, in level 6 we have 5 to 6 is one, I'm not very sure if it is a level 6 yet in this country. So in Kisii County we don't have a level 6. We have a level 5. But politicians want it to be a level 6. They don't understand the risks. You know, there are pros and cons to the levels. As politics in the healthcare, as I mentioned the first presentation, you need to know their game, understand how they operate, sit down with them. After you've understood, that's when you can bring your demands or negotiate what you want, because they will always ask you, what is in it for me? You'll never be given things for free like that. Yeah, all my life in management, I've never encountered a politician who has given me any funding for free. It doesn't mean I give the money. No, it has to be in kind or in some version, but you have to understand them before you engage them. And that is why this facility, it's still a level 5. You asked me, I'll still negotiate for it to remain a level 5 so that we can have control and we can reduce our appetite and make it great. It can still operate as a level 6 because it is a facility that has the most specialists in this region, Western Kenya. The only facility that is giving us a run for our money is Jaramogi, Oginga Odinga, but it's a level 6. You get my point? So we can't compete with it. For level 5s, it is the one that has majority of specialists, so you're able to manage those specialists so long as you reduce your appetite. And Kenyans understand when I say reduce your appetite. So the 4 conditions, we have about 3,300 for hypertension patients in that facility alone. We have 1,700 for diabetes, for cancer patients, and these are the ones we've just managed to diagnose. I know there are many in the community. There are many, okay? And the ones which are stage 1, stage 2, they don't know whether they have cancer. These come in stage 3, 4, okay? And they are the ones we are managing. And that is why resolving their treatment is really expensive, okay? Because if we get them at early stage, we are able to manage them cheaply. And these are the only ones. So with a new baby in the block, still, just like epilepsy, stigma is making us not to have these numbers. How many of you are depressed? How many of you have mental health? Don't raise your hand. Not for today, but ask yourself that question. Have you gone to someone to talk? Okay, so if we all go to talk, let's just go talk to someone. They will tell you the mental health condition you have, and you'll be in these numbers. So we will know whom we are budgeting for. But the problem we are having is we are not talking. We are not speaking it out. Even us as healthcare workers, we don't want. Yet, we've come to seminars, to trainings. Even sometimes we've diagnosed ourselves. True or false? Because if a topic is presented and you know, tick first symptom, tick second, risk factor, tick, you tick almost 70%. Yet you're saying, no, I don't have a mental health. Yet you'll have just gone and discussed. That's why the numbers are not as big as you will expect. But as I say, it's because the mental health is because of us, of stigma. But the others, late detection, we still have like more than 60% of people who don't know that they have diabetes, hypertension in the community, yet we've not reached them. But and that is why the strategy of community health promoters coming in to help in the screening is very important. And all of us to also understand these conditions and talk about them. Next slide. So the strategies that we've come up with to try and respond to the low numbers and sort out our burden, these 4 prongs. The first one, what I love bragging about is patient support center. These are patients that we've been managing them as separate, in a separate unit. Kenyans, you understand that? Patient support center. They are somewhere there in the corner in the facility, okay? And whatever they are being managed are just HIV, TB. Vital signs are not taken, so we don't know whether they have hypertension, diabetes, but research has shown that patients who have HIV and TB, they are predisposed to hypertension. Majority of them have hypertension. And we've gotten many of them in our patient support center when these units in this county started to integrate NCD services in the patient support center. And when Trump came in and he reduced some of our funding, we decided to demolish that unit and now manage them at outpatient clinic in majority of the facilities. So we are integrating that service. That is one of the strategy. As I said, a blessing in disguise, but also a wake-up call to ensure that we change the strategies that we are using to ensure we use our resources efficiently. Next is decentralization of NCD care to lower facilities. Initially, it was just Kisii Teaching and Referral Hospital, and that is why you're seeing so many patients there. But currently, we are devolving, especially in type 1 diabetes. These patients, you know, they don't have transport. The landscape of this county is such that if a patient lives in one corner, for them to get transport, it's like you're preparing for a journey. Okay, you're preparing for a journey. They don't have those resources, so you're preparing for transport, lunch, and sometimes breakfast. Okay, so that's a cost. Looking at that, and now treatment, medication, consultation, those shares come trying to reduce the cost of medication and consultation, but not 100%. There are drugs, you know, with public sector, there are drugs, many times you out-of-stock drugs, and we've heard of out-of-stock. So this is important to decentralize so that we can reduce the cost of transport, those indirect costs. Thirdly is awareness campaigns. We've done so much of shouting, World Health Days, World Diabetes Day, World Hypertensive Month, World Sickle Cell Day, to be able to ensure that the population understands that these conditions are a big burden. And lastly, the school-based screening and promotion, which I mentioned about HPV vaccines and screening of conditions within the schools, like sickle cell disease, which we have periodic school screening with a rapid test to find out who is a carrier, who is having sickle cell disease. So these approaches are being used to ensure that we try to reduce the burden of NCDs. Next, it's the integrated interventions that we have in the county. How are we bringing in the various stakeholders? We are collaborating with partners. These partners, they help in funding one or two of the activities to ensure that they alleviate also the burden of the county in sorting out the cost of running the unit. And we have several partners, and HIV NCD service integration, I mentioned, it's one of integrated interventions that we have. We also have health workers training. This healthcare worker training, it's both in universities, colleges, technical institutes, even lower primary and high school teachings, then in their in-service. And lastly, the CHVs in screening and referral. So having said that, there are challenges that we face in the unit, like inadequate funding, low population awareness, limited diagnostic drugs, and HR gaps. Then our recommendations, next slide, is to ensure that we increase county NCD budget, strengthen HMIS. That is what we say, to ensure that we get health information, and also expand PPP, try to bring private sector, health, faith-based together to tackle this problem, and health workers training and use of digital tools. All this is packaged to try and alleviate out of pocket, alleviate burden from patients, and ensure that we give them quality of care. Last slide is on, just to conclude, is NCDs are a growing threat. We like it or not, it is for us to buy in question. We need to collaborate with the necessary stakeholders to ensure that we give this service optimally. Up to that, probably if there's any question, I'll be glad to answer.
Okay, thank you very much. Thank you. Both speakers handled the IT challenges very well. You can't go yet. So, questions. Right. We got a second microphone to go wandering across there, please. Okay, ladies first.
Thank you very much, Dr. David and Dr. Raymond. It's actually one question in two parts, and it's about resources. You spoke about HMIS systems that are being put in place. Are enough resources being put in place to improve these systems over time, in your opinion, nationally and at county level? And for community health workers, promoters, they're getting more involved in screening. Are enough resources being put in place for training and capacitating them, both at national and county level?
Okay, thank you. About HMIS systems put up in the various counties. Now, we can't say enough resources. What we'll talk about are there are steps being taken, and we are seeing positive steps. An example is what has worked so well in the coast, Mombasa County, and that is one of our footprints or benchmark. They have established HMIS systems from level 5s to level 2s, and there is integration, and that integration has gone to talk with the dashboard of Kenya Health Information System, our database. That includes Muranga. I know for those ones who know Dr. Kangata, he has also used local resources. It's one of the counties we are benchmarking. However, I'll not say there is enough in all counties, but there are counties that have shown it is possible. Yes, we are using those counties as examples to our local leaders. Like in Kisii, a team was taken to the coast, Nairobi, and Muranga. So for Muranga, they saw the local solutions using university students to develop an HMIS, and that HMIS, that the Hospital Management Information System, together with HR system, the fleet system, disaster system, there's one I'm forgetting, even one that the governor himself is tracking staff, whether they've come to work or not. However, there was a lot of back and forth, and now he's just using it for chief officers. However, those are counties that are giving us hope, because there are counties, yes, they are far behind, but those ones, it calls upon to keep on making noise. As a unit, we are one of the units that is making now noise loud. As I presented, the data we are using is step survey, and non-communicable diseases are conditions that they are the only conditions that you are able to budget a whole year. But for malaria, TB, you're using probability. While non-communicable diseases, you can use exact cost if you have the numbers. Like the pharmacists, they usually ask us, how many patients do you have who are using metformin? If I tell them 100, they'll give me a budget. They tell me 100 million. You see, it's just an Excel sheet, and it just throws almost accurate. So your answer is not enough, but we are heading there. For community health units, a lot is being done. 10 years ago, we were not able to regularly pay them their stipend. But right now, like this county, we are only remaining with last month's pay. You get, that is a very good progress. There are counties like Homa Bay, they've paid. They're waiting to pay next month. You see, there are counties that have gone, but it's something in progress, but let's not stop making noise.
Okay. There we go. Next question.
Thank you very much for the presentation. I just have one or two questions on the response strategies for Kisii. One is regarding the decentralization, and I want to comment on the aspect that it's been decentralized to the sub-county facilities. As someone who is very naive with the setup or the distances between the sub-county hospitals and the communities, I'm wondering, is this sufficient enough for the decentralization aspect? Is there any plan or any strategies to actually decentralize further to the health centers that are quite closer to the communities more than the sub-county hospitals? Because I believe this will go further in helping them easily access the healthcare that they need. And then the other part, maybe just to help me understand a bit regarding NCDs and community or religious or personal perceptions, because generally there's this perception that it's not for the young. So I'm wondering what has been done, or what is the plan to deal with? Is there any plans on how to help during the awareness campaigns or discussions in these perceptions, that we can change the community perception so that there is a little bit of ownership or understanding of this, that they can, embrace this much better? Thank you.
Quickly? Yes. Yeah, decentralization, our goal is to ensure we take management of NCDs to level 1. Level 1 is at the community, at the family level. That's why I was asking, are your wives or your husband's children know about NCDs? If we start from there, we are now taking it down. As a government, basically, we said we start baby steps. Ensure that updates are there, even level 5. Then level 4s. Level 4s, now we have medical outpatient clinics. Now patients are coming there. Level 2s and 3s, we are measuring on screening. Already nurses, clinical officers at those levels, level 2 and 3, they've been trained on how to screen. So under CHPs at the community level, we've trained, we are not at 100% because we have 2,980 CHPs in Kisii. We have attained 30% training of CHPs. We are increasing the numbers so that they understand what they are screening. Because all of them, 2,980, have been given NCD kits. So they have BP machines, name them. And these kits are using them in the community. But I know you might, maybe when you walk to the community, you might find a few who don't know how to do them. The other question was on perceptions. This is an ongoing thing. We are doing awareness campaigns. Like next week on Friday, we'll be having a medical camp. We're having outreaches, and we are having discussions in churches, burials. You know, in Kisii here, every Friday and Thursday, it's a burial day. Hello? Yes. So we are taking opportunities of those moments to discuss about this.
As you asked the question, I thought, have you seen the program for the rest of the 5 days? Because exactly what you described about communication with communities and getting right down to the villages will come when Evans Mocha, see, when they were talking, School of Arts and Languages, what are they doing here at an NCD conversation? That's exactly why they're here, because the community-based organisers are here to have a conversation with us about how we get this message out to the villages away from the centre. So I'm delighted to hear David talking about how the system is trying to push it out to the communities, but we need to prime and develop the communities to be ready to receive and understand what's being pushed out. Much more of that on days 2, 3 and 4. Take a breath, hold your breath. Next question. Was there somebody else?
Yeah, thank you very much. My question also is regarding the leveling system of your healthcare. And this level 1 to 6, I think, is new to me, because what I'm familiar with is primary, secondary, and tertiary care. So as you are explaining the levels and their characterizations, I was trying to see which level correspond to my primary, secondary, or tertiary, so that would be easier to remember. When I go back home, I will be telling my colleagues about Kenya, and then it will be either. Now, from what I understand, is your level 1, 2, and 3 clearly fall within our primary care, level 4 and 5 within secondary, and then level 6 is essentially tertiary care. The only outlier is that you offer theater services in level 3, and I found that to be an outlier. So I'm wondering, is it practical, and how is it in the field, in the facilities? Like, is it practical that you're offering theaters, or is it theoretical? So that's
Keep your
question.
microphone near your mouth, mate.
I think that's my question. Thank you.
Okay. Raymond, do you want to answer that one for me?
Thank you for your question. Yeah, I think our level 1, 2, and 3 is what is called primary healthcare. And you are right, secondary healthcare is 4 and 5, and tertiary is level 6. I think this was, we also used to be like that. This is just a recent change. But what was the second question? Yes. It is practical right now because it's not really primary, it is the secondary, because it's from level 4. It's from level 4, it's not the, am I right, Dr. Kinyi? Oh, the maternity. Yeah, you want to add something? David is more with the county right now, with the university.
Yeah. For level 3 is the maternity. We call it EMOC services. Yeah, there are EMOC services introduced in level 3s because of the increasing maternal mortalities. So you'll find a few having theaters. And in level 3s, we have 3A and 3B. So 3As will have theater, 3B will not have.
Comparing health systems is like comparing different sorts of fruit. You've been, in presenting that here today, the idea was to give you a feel for the way that Kenya is approaching its system. I can tell you, if you pick the Ugandan system, it looks pretty similar. There's a little bit of variance, but it looks about the same. You try to put that on our National Health Service in the UK, it looks nothing like it. And when you're approaching NCDs, the key message is we're trying to push it out into the communities, to de-hospitalize it and make it a part of your normal existence. So watch this space as we go through. We're not trying to present, this is how it should be done. It's how it's done here and how it works for Kenya. But every system needs to have a structure, decide at what level is what done. When I'm looking at the ambulance service activities in Kenya, and Kisii in particular, there is a huge amount of moving mothers up the chain to hospitals that have different levels of surgical intervention. You will not get away from that. It's the obvious consequence of trying to push maternity care into the community that people will be identified in the community that needs to be in the centre. So the system needs to be designed to manage its population. I am acutely aware that it's 10 past the lunchtime hour. There was one more, save the best till last. This will be a killer question. Just wait for it to.
Yeah. So I'm curious on what your guys' vision is on how NGOs and maybe specifically MSF should be involved in NCD care in your county.
Can you pause that? Because when we get to that on day 4,
okay.
David's quite right, and David can certainly answer that, but I'm aware there's another question and it's lunch, and I know it's coming up in day 4, because what we're presenting here today is how the system works, however well it works, and how we layer on the NGOs and the extra services will come as we progress through the module. Good question, press pause button, ask on Monday.
Okay.
Final person to speak.
All right, David, thank you for the presentation. So prior to your second part of the presentation, I was wondering, integrating both NCDs and communicable diseases. As we know, despite the epidemiological transition, we are at a point where we have double burden, right? We have both persistent NCDs and CDs, and then we are now having NCDs. So I'm glad you talked about integrating HIV care and NCDs. So following your principles, in what other aspects can we integrate both? Because I think having a more of a horizontal approach would be better than just going vertically NCDs. So in what other ways do you think, based on your principles, we can integrate both NCD controls and then CD controls together?
The controls, personally, in the county, we are focusing on when we are having things like awareness campaigns, we do them both. When we are managing these patients in the clinics, since we got that beating from Trump, we are having these patients being seen at outpatient. So we are able to screen these patients as they come to the clinic, and we see those who have the comorbidity, that is HIV, TB, and NCD. We see them at the MOPC. So they don't need to come to different clinics. So we see them at once. So in that sense, it means the clinician who's seeing these patients must be trained on NCDs, must know about HIV, so that it's a wholesome management. It's not that he's just treating HIV and calls another person to treat NCDs.
And does that really work effectively? Because we have specialties, right? The infectious disease specialist is one, and then probably the cardiovascular specialist is one. So how do you?
Yes. Now, this thing works, especially, you know, we grade these patients. There are patients who are complicated, who will really, really need a cardiologist or a nephrologist. But there are patients who are not complicated. They can be treated by a clinician or a medical officer. So this clinician, medical officer, they are not specialized. They know how to treat the HIV patients, especially the patient support centers. Rarely do we have infectious disease specialists. Rarely in Kenya. Actually, it's only one hospital that I've seen an infectious disease specialist at the patient support center. The rest are being managed by clinical officers and medical officers. So how effective is it for ourselves? It's we are using even family physicians who are able to treat HIV, TB, NCD. So take advantage of that, especially the sub-county hospitals. We are having family physicians rotate in those MOPCs and see patients there. So we are able to kill two birds with one stone.
Sorry, there were some of the non-verbal communications. We thought we had a question online, but it's been withdrawn, I understand. So they are watching, they're listening, and they're wanting to ask questions. And Raymond said, Dr. Susan, who is also from Kisii University, wished to say a few words. I need to remind you, you are between them and lunch.
Thank you so much for the opportunity. My name is Susan. I head the Department of Nutrition in Kisii University. And having listened to this presentation today, I see it really fits into what we have, the vision and mission of the department. I came late, sorry, because I was assessing students at the hospital. And most of this that has been mentioned here is what we see at the hospital. So I was just curious, like, sometimes we see students collecting data at the hospital, and at the same time we have other NGOs doing almost the same thing. And I thought, since we have our MSc students on board, why can they be integrated in the program? They collect this data, they do very good work, they give this information. At the end of it all, the student will gain by getting the MSc, and at the same time the data can be shared with even the non-governmental organization. So I just wanted to bring that. I'm sure it maybe come up in some of the presentations ahead, but I just want to mention that and know that the Department of Nutrition exists here. Thank you so much.
Thank you, Susan. Okay, thank you for that.
Question in your email.
The question on my email. Oh, that's convenient. Okay. Lunch is going to be a few minutes. That gives us a window for the online question, which comes from the online. I'd like to learn about how you manage resources in the NCD program, especially as the burden of morbidity continues to grow over time. It's valuable to hear about your experiences and strategies. That's a very broad question. It doesn't say who it's come from. Management of resources in their NCD program. Okay. Invite you to say a few words about the management of resources.
Thank you. For resources in the NCD program, we don't have a separate budget given to the unit, okay? But we tag along the budgets that are being made in various facilities. For example, KTRH has its own budget, and that budget on drugs, on non-pharmaceuticals, on awareness campaigns, so we ride on that. However, as a unit, I know 95% of the time we are using, we are depending on donor funding currently. And that's why I'm saying, yes, there's light at the end of the tunnel. The facilities are budgeting, yes. The unit is not being given its own specific budget, but we keep on making noise. The one budget that we have from donor funding, the funding that they give us from their kitties is what we can draft down. For example, if we have an awareness campaign, request this donor to fund our awareness campaign, or if we have a training, we request them to train for us. So they have some budget as an NGO, but not as a unit, our own budget. Okay, that's how we survive.
How you survive. Right. I think I'm going to draw a line under it at that point for this morning. We started off with global strategy. We've come down to national strategy. David, thank you for that. We've talked about the health system in the country, and then we've started to get into the specifics. I'm going to pause it. We are going to break for lunch. Lunch is in the Senate room. We will lead you to that. It's one building across, so it's about 100 yards. And we will take you across there for lunch. They said they'd be ready in 15 minutes. As always with these things, time slips, which is why I'm really keen to stick to time. If we are finishing, I'm going to take this as a 1:45 finish. Can I bring us back together at 1:45? At 1:45, we are going to have a presentation from Peter, and then we're going to break you out into some groups, and I will brief you as to what you're doing. We will have afternoon tea, and then we will have a plenary with the speakers up here, and there will be a chance for conversation. I've been making notes as the morning's gone on. There's some very pointed questions, accurate questions about detail, and we will try bring those things out in the after break conversation plenary session to really get into the detail. Okay? Starts are always very formal. We're now getting into the detail, and what I would ask you to remember is every country is different. Every region is different. We are showing you Kenya. Take the good stuff from Kenya and see if it will fit into your system. And maybe this afternoon you'll have some good stuff that you've got. That's the group work you're going to be doing. The good stuff that you've got that everybody else could learn from. That's the aspiration from this afternoon. So the online, you've got just under an hour to go and do what you need to do and be back with us. Thank you. For those of you in the room, thank you for your attention this morning. Grubs up, and to the speakers this morning, I'm getting two messages. One from Adele that says Senate room, the other said down there. Raymond is likely to be more accurate because, however, follow Raymond and Adele to wherever the food is. This is coordinated organisation, isn't it? There will be food It's somewhere. I'll see you again in 55 minutes. Thanks, folks.